coordinator and examiner for fellowship and certificate course in reproductive medicine for Rajiv Gandhi University of Health Science.
Hello? Hello?
Yeah, we can hear you. It's just that there's some lag, so you can keep your video off maybe and continue.
Can you hear me, Amol?
Yes, yes. Yes, we can hear you. Yeah.
Okay, I'll do that. Yeah, I'll do that. Okay. Yeah. We can see that the LHCGR expression is maximal in the granulosa cells in the pre-ovulatory follicle just before ovulation, and the FSH receptor expression reduces steadily as the follicles increase in size and maturity, and the receptor expression mirrors the follicular responsiveness to LH and FSH during the follicular phase, indicating that LH is important in the second half of the follicular development. And here we can see that LH binding has a greater impact on the AKT as well as on the extracellular signaling regulated protein kinase phosphorylation, whereas HCG binding to these receptors generates a greater intracellular accumulation of cyclic AMP. And basically, this HCG, which has a greater stability, and it is almost about 5 times more potent than LH in increasing the cyclic AMP production, which is the second metal for ovulation as well as steroid biosynthesis, and therefore and also has a prolonged eutotrophic effect. Coming to this study, which was again done in vitro on the granulosa cells, and where they looked at the effect of LH and HCG at 15 minutes, 48 hours, and 72 hours on the PERK1-2 activation, PAKT activation, as well as on the pro-caspase. And what they found that the LH treatment induces higher levels of both then the HCG, and this was statistically significant. Whereas the HCG at 15 minutes, basically we have higher levels of PCREB activation than LH, which results in the production of caspase enzyme. And then if you look at the cell viability, it was found that there is a positive effect on the viability of cells which are maintained under the LH exposure over 72 hours, while the treatment by HCG decreases the cell viability. And there is a significantly higher PAKT activation which occurs in the presence of 17 beta estradiol within the time range of 15 minutes to 48 hours compared to the controls. And then this presence of 17 beta estradiol does not depend whether we have used LH or we have used HCG. And thus the gonadotrophin mediated pro-apoptotic signals are abolished by as in the follicular phase, the estrogen increase of LH as well as HCG decreases, and it basically becomes anti-apoptotic, and it has also an overall decrease in the cell viability in all the samples after 72 hours. And therefore, this study et al. That the action of LH and HCG is totally different in vitro and in vivo. And in vitro, what happens is basically the proliferation role of LH exerted during the folliculogenesis is reflected by the activation of EARK1-2 as well as AKT pathways, and anti-apoptotic gene expression and increased granulosa cell viability. Whereas HCG displays a higher steroidogenic potential mediated via signaling pathways which are linked to apoptotic signals in vitro, resulting in pro-caspase 3 cleavage and decreased cell viability. And this is totally in contrast what is observed in vivo during HCG supplementation in control ovarian stimulation, where it's modulated by estrogen, which counteracts the pro-apoptotic HCG mediated signals, and therefore it becomes anti-apoptotic. And if you look at the role of both LH and HCG, we know that it helps in the initiating the antral as well as the preantral follicles and thus increasing the recruitability of the follicles. There is increase in the FSH receptor and thus it increases the responsiveness. It has an anti-apoptotic effect on the granulosa cells and it also acts synergistically with IGF-1 which results in the growth of the follicle. And it has been seen that there is a balance between HCG and FSH that is required and this then determines the follicular maturation. It has been seen concentration of androgen and estradiol towards a more can result in arrested follicular growth as it antagonizes the estrogen-induced granules around the follicular diameters of 8 to 11 millimeters, which is corresponding to when the follicular selection occurs. FSH also promotes the follicular growth by downregulating the androgen receptor expression and stimulates the aromatase conversion of androgens into estradiol. And here again, we can see that the HCG reduces the occurrence of the small preovulatory follicles because we can see a high number of small follicles in the FSH only group. And later on, when we see that there was no significant difference in the other follicles, that is, there's no significant difference in the median or intermediate and large follicles in the different groups of patients. So you can see when you give no LH activity, the number of follicles which are less than 10 millimeters are significantly higher as compared to when LH activity is added. And in this study, which was a prospective RCT, where they gave different doses of HCG, which was about 0, 50, 100 and 150 international units. When they looked at the size of the follicles on the day of HCG trigger, what they found that the total number of follicles according to the different size categories are similar in all the 4 groups. This study then further looked at the quality of the embryos and what they found is that the quality of the embryos was significantly higher when HCG was administered and the dose which was best was 150 international units, which gave significantly higher top quality embryos as compared to 50 international units. But if you look at the cumulative pregnancy rate, implantation rate, as well as the pregnancy rate, you can see that there is no significant difference. And if you look at the various studies which have been published on administration of HCG in the early follicular phase, wherein as shown in the previous slides, different doses of HCG were used from cycle day 2. And when we talk in terms of clinical efficacy and safety, HCG supplementation up to a daily dose of 100 to 150 international units was proposed and was associated with better quality embryos. It also reduces the cost by decreasing the amount of exogenous FSH required and by shortening the treatment duration as well as the monitoring. In terms of safety, the incidence of OHS is similar, that is, addition of HCG did not increase the incidence of ovarian hyperstimulation syndrome. And in this article, which was published in Reproductive Biology and Endocrinology, they compared HCG versus REC-LH in a GnRH agonist long protocol. And what they found is that the total dose of FSH was significantly lesser with HCG. The number of follicles, the oocyte number, and the number of transferable follicles was statistically significantly higher in the HCG group. And when these other studies looked at the role of HCG supplementation in the mid to late phase ovarian stimulation, where the dose of HCG was anywhere between 200 and in all these trials, basically HCG was added once the follicular was 12 to 14 millimeters in size. And here you can see that the LH, the estradiol, and the total testosterone were significantly higher with HPHMG, where HCG was used as an LH activity. And in this paper, which was published in February 2014 in JCEM, what they concluded was that there were significantly higher intrafollicular concentrations of E2 and progesterone with an androgenic milieu, which was associated with good quality embryos. The E2 to P4 ratio was significantly and inversely related to the good outcome, indicating that most competent oocytes were generated from follicles, making the timely transition to the progesterone production. And in terms of clinical efficacy and safety, HCG supplementation in a daily dose of 100 international units was proposed in this study. And if you look at the other effects, we know that it shortens the treatment duration and monitoring as well as improves the folliculogenesis. That it also selectively reduces the occurrence of small preovulatory follicles and thus potentially reduces the risk of ovarian hyperstimulation syndrome, thus procedures. There's also decrease in an average FSH administration dose by almost 1,000 international units, and the significantly higher E2 level on the day of HCG, resulting in more estrogenic intrafollicular environment, results in significantly higher fertilization rate in patients receiving HCG versus REC FSH alone. And it was also observed that there were significantly higher clinical pregnancy rates. So I'd like to conclude by saying that LH and HCG are expressed in all stages of women's lives after puberty. In adult women, LH and HCG secretion shows regular pulsatile pattern during the menstrual cycle. LH and HCG have complementary roles in reproduction as well as normal physiology and have similar structure but are not the same molecule, and an addition of CTP extension confers HCG an extended half-life. Both molecules bind to the LH-CGR receptor but are associated with quantitatively as well as qualitatively different intracellular signaling. Follicular maturation is controlled by LH-CGR expression in the theca as well as the granulosa cells and by the hormonal interplay between HCG and FSH. The apoptotic effect in the granulosa cell is associated with HCG in vitro but not replicated in vivo even in response to high HCG doses. The ovarian stimulation with HCG in vivo supports the granulosa cell growth and oocyte maturation reasonably through upregulation of the proliferative signals. The effect of single compound at the molecular level may not be detectable in vivo due to complexity of the background and the concomitance of several opposite signals. Thank you.
Thanks a lot, Dr. Madhuri, for that first lecture related to HCG-driven LH activity, and I think that sort of sets the tone for the next session. So after the introductory talk, we're gonna start Megaset HR soon, and before that, we just enter into the space of high responders. So this is just a short survey results from 17 experts. Of course, it was a very informal survey, just threw 10 questions. And one of the questions was, how do you define patient as high responder prior to the cycle? So needless to say, nearly everybody said it's high AMH and AFC both that would be considered to define a patient as high responder. So this is just trying to take some insights, practical insights. And what would be the cutoff number of oocytes if you want to define a patient as high responders? That had quite a variable response, with 15 as the cutoff oocytes told by 9 experts, and roughly hovering between 18 to 20 by the remaining of them. Now, what percentage of our patients are high responders? That was again a variable response, but roughly 10 to 30% of the patients are high responders. It's what was coming out in general. And what is your primary concern when you treat your high responder cases? So roughly 12 of them very, very obviously told that OHSS is the primary concern. But along with that, we had few responses which said that, I mean, the experts said wherein that choice of gonadotropin or dose of gonadotropin is also an important concern. Option in terms of fresh or frozen transfer, unanimously it's coming out that frozen transfer would be chosen in high responders. And then coming to the question, which would probably be more discussed in detail going ahead in this meeting today, is what is your choice of gonadotropin? So 4 of the 17 were saying RFSH only for high responders. 5 were saying only HMG, while the remaining ones were hovering that they will use both RFSH and HMG, either from day 2 of stimulation, or they would go ahead and add HMG from day 6 of stimulation. So that was the difference. And starting dose, more or less, everybody was agreeing that 150 IU would be the starting dose, with few responses related to 112.5 or 225 IU as well. And the last question was pertaining to whether you would really think that LH activity is needed in predicted high responders. So it was like majority have said yes. And if they say yes, the reasons are like we may get a greater percentage of top quality embryos or better and competitive site selection, or it moderates the number of recruited follicles. So some of these reasons. And if they believe only in using RFSH exclusively, then maybe that most high responders have PCS-like profile and they're already having sufficient LH activity, so may not need the same. So with that, we moving to the next part of the agenda. That's versatility of LH activity in high responders. Focus on megaset HR. This will be a joint talk by Dr. Manish Banker and Dr. Kevin Doody. And it gives me a really great pleasure to introduce Dr. Manish Banker. Of course, sir doesn't need an introduction, but a short glimpse. Sir is the Executive Director of NOVA EV Fertility Clinics India, Course Director for the Fellowship of Reproductive Medicine offered by the National Board of Examinations and also by NOVA EV Fertility. Past President, Indian Society of Assisted Reproduction, and Sir sits on the International Affairs Committee of ASRM Board of Directors.
The issues with antral follicle count is the problems related to standardization, because there are a lot of inter and intra observer variations, because it is primarily dependent on the skill of the person carrying out the ultrasound examination. AMH, on the other end, is getting more and more standardized and can be reliably used across clinics across different countries. And hence, whenever we look at any clinical trial, it is possibly the number one ovarian marker which has been considered for all of the trial. And it is the AMH which is generally used to guide the gonadotrophin dosage in all study settings. If you look at the evidence from literature, both antral follicle count and AMH, both are almost equally effective in predicting the extremes of response, both poor response and excessive response. And the area under the curve for both this from this fairly old study from 2009 shows that the area under curve for both is more or less similar. And either alone and more so in a combination, they are more effective than serum FSH and the patient's age in predicting extremes of ovarian response. The second question that comes to everyone's mind once the dose issue has been resolved is to what type of gonadotrophin should we use? Should we use HMG or FSH, and should we use the recombinant preparations or the highly purified preparations? As was evident from the survey which Amol shared just a few minutes back, opinion was almost equally divided between REC FSH only, HMG only, and a combination of FSH and LH, the LH being or the HMG being started either from day 2 or from day 6. And this has been seen across the globe because different clinicians use different combinations of HPHMG and REC FSH in their stimulation protocol. And the major reason behind this is that there is absence of robust high quality evidence which would demonstrate the superiority of one over the other, or whether a combination is better than them alone. In addition to there is also a lot of heterogeneity in the ratio in which the FSH and LH components have been used. And because of this, we still do not have a standardized algorithm on choosing the type of gonadotrophin based on the patient profile. We also know now, again, a publication going back to 2012, that the LH receptors are expressed on the theca cells from fairly early antral follicle state. And if you look at follicles which are less than 5 millimeters, possibly they do not have LH receptors, but the moment they cross this 5 millimeter threshold, more than 80% of the follicles start exhibiting LH receptors. So we know that the body does need LH from very early on in follicular development for adequate and optimal folliculogenesis. The other challenge that everyone faces in their clinical practice, and that is what the megaset HR trial is focused on, is the issue of high responders. Now, again, there is no one standard definition to define a high responder, but typically, a patient who produces more than 15 oocytes is defined as a high responder. The major challenge in these high responders is the risk of ovarian hyperstimulation, and this leads to multiple options if it is very severe, sometimes cancellation, or by and large in today's time is an agonist trigger, all freeze approach. But this then causes an undesirable delay from a patient's point of view and increases the cost. There is also some evidence coming in that all freeze cycles, babies are at a higher risk compared to a fresh embryo transfer. So, what we need is to define a stimulation protocol for this high risk patients as to how do we stimulate and at the same time minimize the risks. Now, Ferring has conducted three trials till now, the EISG, the MERIT, and the MEGASET. In all the three trials, serum AMH was used to define the patient's ovarian reserve. Patients were then randomized between HMG-HP and recombinant FSH. And what was observed in all the three trials was that in potential high responders, that is, those who had an AMH of more than 5.2, the use of HMG-HP was associated with a lower number of oocytes, had a lower incidence of high response leading to more than 15 oocytes, and they required fewer interventions for ovarian hyperstimulation and had an increased live birth rate, irrespective of whether it was the agonist or the antagonist protocol. So this is the data from all the three trials. The blue bars are patients who were put on HMG-HP. The black bar are those who were on the REC-FSH. And if you look at the ongoing pregnancy rates, in all the three trials, it was significantly better with the HMG-HP stimulation as compared to the REC-FSH stimulation. Keeping this in mind, let us see what did the megaset HR trial throw up. So the megaset trial was a trial where patients were blinded into giving HMG purified and recombinant FSH in a GnRH antagonist stimulation followed by a single embryo transfer. And if you look at all the results from patient population or intention to treat in all the parameters from a positive beat side CG right up to a live birth rate, the HMG group fared better. Following these trials, there was also a post-hoc analysis by considering only those patients who were high responders or those who had a high AMH. And in this select subset of patients of high responders, the graph on the left shows that HMG-HP gave a significantly higher live birth rate of 42% compared to 26% with the REC-FSH group. When we look at the incidence of OHSS or safety interventions, we can see that based on the quartiles of AMH, the lowest responder to the highest responder, the moment we move to the quartile 4, which are the patients who are the suspected high responders, the safety profile of HMG-HP was significantly better as compared to recombinant FSH. So this is what the retrospective analysis of the data of the MERIT and the megaset trial showed, that if we analyze the patients in the highest AMH quartile, that is those who have an AMH above 5.2, they had decreased number of oocytes, decreased early OHSS and safety interventions, and an increased live birth rate per embryo transfer with HMG-HP versus REC-FSH. So there is something that HMG-HP is doing for these high responders, which REC-FSH is not able to do. We also know that giving an agonist trigger to high responders is not 100% safe. We have ourselves published 2 papers on this showing severe OHSS in an agonist trigger with freeze-all approach, and even a spontaneous pregnancy with severe OHSS in patients who had an all-freeze policy. And if you look at this meta-analysis, which has 7 studies, 5,011 patients, again, the overall risk of OHSS was lower in the FET group than in the fresh ET, but still, it was still present. So an agonist trigger only eliminates the late onset pregnancy-induced OHSS. Early OHSS can still occur with a much lower frequency, but it can still occur. So keeping this in mind, the megaset HR trial was initiated as a non-inferiority trial to prospectively evaluate the efficacy and the safety of HPHMG versus REC-FSH as per the earlier protocols as a proof of concept in a predefined population which was predicted to be a high responder. So the other trials were for all categories of patients. This trial, megaset HR standing for high responders, was focused primarily for predicted high responders. All of these patients then had a single embryo transfer, a day 5 single embryo transfer. This was one of the prerequisites of this particular study. Let us look at the inclusion and the exclusion criteria. Patients typically aged between 21 to 35 years, having fairly regular menstrual cycles, normal hormonal levels, normal BMI, but having an AMH above 5, that is with a possibility of a high response, and those who willingly accepted for a single embryo transfer. Patients having a known poor response or predicted poor response, like patients with advanced endometriosis, low antral follicle count, or who were on birth control pills, or had previous ART failure due to poor response, were obviously excluded from the study. What was done in the study was patients were randomized to HPHMG or REC-FSH, which was started in a dose of 150 units for a period of 5 days, beginning second day of the period. After 5 days, based on the response, the clinicians were allowed to alter the dose by adjusting it by 75 international units if required. The antagonist was used as per the flexible protocol, that is when the lead follicle was 14 millimeters or above, and or when the serum estradiol levels were more than 300 picograms per ml. When 3 follicles reached a diameter of more than 17 millimeters, the final trigger was given with REC-HCG 250 micrograms. An agonist trigger was reserved for those patients who had more than 30 follicles of more than 10 millimeters or who had an E2 level exceeding 5,000 picograms. All of the patients had an oocyte retrieval and embryo culture till day 5, where patients who had been triggered with HCG had a single fresh blastocyst transfer, and the luteal support was with standard vaginal P4 100 milligrams twice a day. HCG testing approximately 2 weeks post the embryo transfer, and the subsequent monitoring was like any other pregnancy, and an ongoing pregnancy was defined as one that progressed beyond 11-12 weeks of gestation. The primary endpoint that was studied was the presence of an intrauterine pregnancy with a fetal heartbeat at 10 or 11 weeks, or an ongoing pregnancy rate per cycle initiated. And the secondary endpoint studied were number of cycles that ended up with ovarian number of oocytes retrieved per OHSS, the cumulative ongoing pregnancy rate, and the early pregnancy loss. This study was then extended following the fresh embryo transfer for patients who had frozen blastocysts for a period of 6 months. Up to 3 frozen cycles were taken and the cumulative live birth rate calculated. So this is how, based on the background of whatever information was available, the megaset HR trial was initiated. And I would now leave to Dr. Kevin Hoodie to discuss with you the results of this particular trial. Thank you very much.
Thank you. Well, first I'd like to say thanks to Amol for the kind introduction, and thanks to Ferring for allowing me to be here this morning. I appreciate Manish you setting this up to discuss the results with a very good introduction of the background and the study design. So my role today is to talk about the efficacy found in the megaset HR trial. So we'll start with a flow diagram. As we can see, this was a large trial. As was mentioned, 620 patients were randomized to highly purified HMG or recombinant FSH. There was one patient that did get pregnant prior to randomization or immediately following randomization. So that explains the difference, slight difference in the numbers between the Menopur and the Rec FSH arm. Almost all the patients completed through day 6 of stimulation. We can see that 293 patients underwent trigger in the Menopur arm compared with 307 in the Rec FSH arm. It's also notable that there was a difference in the proportion of triggers that were conducted with HCG versus GnRH antagonist, with more HCG triggers in the Menopur arm compared to the Rec FSH, slightly more, and far more GnRH agonist triggers in the Rec FSH arm compared with the Menopur. We can see that there were several patients that were discontinued either for protocol violations or cycle cancellation. There were more of these, 21 in the Menopur arm compared with 7 in the Rec FSH arm. There were a total of, in the extension study, there were a higher proportion of patients that had frozen embryo transfers in the Rec FSH arm, 130, compared to 82 transfers being done with the Menopur. So a little bit of differences foreshadowing the results. What we note here when looking at the baseline demographic data is that there were substantially no differences in the 2 study groups with regard to any of these parameters: age, BMI, baseline hormonal concentrations, antral follicle count, etc. It is, I think, important to note that the AMH was relatively high in each of these arms for patients that were having cycles, if not completely regular and predictable. They were cycling patients, not typical PCOS, but with a mean of 7.8 and 7.5 nanograms per milliliter AMH between the 2 arms. So the stimulation results were somewhat different between the 2 arms. The duration of stimulation was 10.9 days in the highly purified HMG versus 9.3 days in the Rec FSH. The mean total gonadotropin dose was also higher in the Menopur arm compared to the Rec FSH, 2,100 international units compared with 1,500. A higher proportion of the patients with Rec FSH had their initial dose maintained. As you recall from Dr. Banker's discussion, the patients were allowed to have adjustments in their dosage of 75 IU beginning on day 6 of stimulation, and this happened more frequently in the Menopur arm. One of the big findings in this trial was that there was a significantly higher production of eggs in the Rec FSH arm compared with the highly purified HMG. And it's interesting to note, I think, that if if we analyze gonadotropins based on simply egg production and not as a surrogate outcome measure for live birth, that we would have concluded that there was substantially difference in favor of REC-FSH. I'm going to foreshadow this a little bit and say the study doesn't find this. The number of cycles with excellent blastocyst was in fact quite similar between the two arms, and the number of subjects, or the percentage of subjects with a fresh embryo transfer, was actually slightly higher in the Menopur compared with the REC-FSH arm. The number of subjects with a frozen transfer was lower in the Menopur versus the REC-FSH. So we can see that the baseline estradiol levels were similar between the two arms, Menopur and REC-FSH. But on day 6 of stimulation, the estradiol serum concentration was quite a bit higher at 3,200 in the REC-FSH arm compared to almost 1,200 in the Menopur. And on the day of final day of stimulation, although that had tightened somewhat, there was still a higher estradiol level in 1,180, 822 picomolar versus 10,071. So there are many accepted ways to calculate ART success, and each has advantages and disadvantages. Although the primary endpoint, ongoing pregnancy rate per cycle start, is the most likely measure to underestimate success, as only those patients who have a live birth per started cycle are considered successful by this estimate. So the ongoing pregnancy rate was slightly higher in the Menopur arm compared with the REC-FSH. You can also look at success in terms of live birth rate per transfer, and because there were some patients that did not get an initial fresh cycle transfer, you can see that these numbers are higher than the per cycle start. And again, they're fairly similar, but numerically slightly higher in the REC-FSH arm at 52 compared with 48.7. The surprising finding, one of the secondary endpoints is early pregnancy loss, was that there was a dramatic difference in the risk of miscarriage in the REC-FSH compared with the Menopur. So nearly 24% of patients who conceived with REC-FSH wound up with a clinical miscarriage, whereas that was only 14% in the Menopur arm. So in this study, as I mentioned, the difference in the number of oocytes retrieved was 7 fewer in the Menopur arm, and this importantly narrows as we look at the events in the laboratory. We see that although this difference was 7 in terms of the number of egg retrieved, this was an ICSI study, so we were able to quantitate the number of metaphase 2 mature eggs, and the difference was just a little over 5. And if we look at the fertilized eggs, the difference was a little bit over 4. And as we look at the number of blastocysts on day 5, the difference was just under 3. And if we look at the number of high-quality blastocysts, numerically very little difference between the two, at 3 in the Menopur arm and 3.9. So although a 50% higher number of eggs were retrieved in the REC-FSH arm, that translated to a far lower number when we were talking about potentially competent embryos. Which brings us to the extension studies, and again, up to 3 frozen embryo transfers were done. We can see that surprisingly, the success rate, the live birth rate per frozen embryo transfer, was substantially higher in the Menopur arm at 63.4% compared with just under 51% in the REC-FSH arm. Now, one speculate that the increased risk of miscarriage in the fresh cycle with the REC FSH might have been due to endometrial effect of the apparently higher stimulation. This does not appear to be the case, because the pregnancy loss in the frozen embryo transfers was also significantly higher in the REC FSH arm at nearly 28.6%, compared with approximately half of that, 14.5%, in the Menopur arm. And if we look at the miscarriage rate, combining both the fresh and the frozen, again, we see that dramatic difference, 14.5% versus 25.5%. And this, again, is statistically significant, and I think quite a surprising finding of this study. So looking at the clinical live births after fresh and frozen, they were actually quite similar in the Menopur and the REC FSH treated patients, 50.6% versus 51.5%. What's important to note that although the success rates, including the fresh and frozen transfers, was nearly identical between the two groups, the live birth rate was achieved with far fewer embryo transfers in the Menopur arm. So there were 43 fewer transfers in the Menopur compared to the REC FSH. And if we look at the number of embryos transferred, this was even more dramatic. So there were, again, these same live birth rates achieved, transferring 65 fewer embryos in the Menopur versus the REC FSH. Which leads us to safety, very important. So the number of treatment emergent adverse events was higher in the REC FSH. The percentage was 58% in the Menopur compared with 71% in the REC FSH. And this really increase was due not to the procedural pain, nausea, headaches, constipation, or other symptoms. It was due primarily to the OHSS, and we'll look at that a little bit more closely. So the percentage of patients that had ovarian hyperstimulation syndrome, all grades, was 21.4% in the REC FSH arm compared with 9.7% in the Menopur. And this was, I think, most dramatic with the early OHSS, which was nearly threefold higher in the REC FSH compared with the Menopur. So in conclusion, in predicted high responders, the ovarian stimulation with Menopur provided a good safety profile without compromising the efficacy. The Menopur was non-inferior and really nearly identical to REC FSH with respect to ongoing pregnancies. There were comparable clinical live birth rates in the Menopur, but it was associated with a fewer number of transfers that were required and a lower number of transferred embryos. So the higher ovarian response with REC FSH led to a higher incidence of OHSS, but did not confer any clinical benefit with regard to live birth. And I think the final takeaway is that there was a reduced early pregnancy loss, which we know can be devastating for our patients, leading to ultimately delayed treatments and emotional burdens. So when putting this together with the other trials that were done comparing REC FSH to Menopur that Dr. Banker had mentioned earlier, I think it's important to credit that there's really been a large investment into clinical trials over the past 2 decades that have consistently demonstrated the efficacy and safety of Menopur in ovarian stimulation. These 4 studies have all compared gonadotropin treatment and in aggregate in both IVF and ICSI cycles, and they demonstrate comparable results with respect to the ongoing pregnancy rate. So here we can see the question has been answered. The primary endpoint, which was the ongoing pregnancy rate per ovarian stimulation, was 35.5% compared to 30.7%, which follows in the trend of the 3 prior studies. And with that, I'll conclude.
Thanks a lot, Kevin, for that elaborate results and conclusion of the trial in terms of efficacy and safety and the primary and the secondary endpoints of the study. So now we open the forum for Q&A session to our 2 speakers of the session. So I request all the delegates of this meeting, you have an option on your landing page to post your question, and you can type in the question. It would reach here to us and we can ask you to our esteemed speakers. So meanwhile, the questions will be coming. The first question that I wanted to post to you is, what would be the reason for consistent diminished number of oocytes observed with HPHMG as compared to recombinant FSH?
So I'll jump in there. I think there are really 2 explanations for that. One could be that it's the HCG activity that's causing an atresia of some of the less mature or less competent follicles. Or the other is that certainly the Menopur and the Chinese hamster ovary produced REC-FSH are different. So their amino acid sequence is certainly the same, but their glycosylation is different. So there are different isoform profiles that certainly could have different biologic activities that would impact on the number of eggs that would be produced.
Would this also be the reason, Kevin, why patients take 1.5 or 2 days longer than the REC-FSH group?
I think so. So, it would be interesting. We know now, I think we understand quite well that some patients, especially with a higher body weight, will require a higher dosage of gonadotropin in general. And because there does appear to be a difference in the bioactivity of the 2 different gonadotropin preparations with regard to egg response, it would be interesting to repeat this trial at some point using a starting dose that is adjusted based on body weight.
Okay, thanks both for your comments on that question. Well, one more question is that, which is very typical, is that in high responder patients, generally the LH levels tend to be higher. So does it make sense to add an LH activity containing gonadotropin therein? Because maybe it may turn out to be detrimental to the follicles or something like that.
So I'll jump in again. I think it's important to distinguish LH levels in a natural state, either in a spontaneous cycle or in a PCOS patient that isn't cycling, and those LH levels that are present during ovarian stimulation with gonadotropins, because as gonadotropins are given, the estradiol production by the ovary increases, serum estradiol level rise, that feeds back to the pituitary gland and very promptly suppresses the LH production. So although in the beginning of the stimulation in a cycling patient or a PCOS non-cycling patient, one might see adequate levels, but in a short time frame, there's a relative deficiency of LH. So it does make sense, I think, to have it as part of the stimulation protocol.
Dr. Banka, any comments on that query?
Only one comment I would make, that what the question is based on physiology, but at the same time, we also need to look at what is the evidence, because sometimes what we assume based on physiology does not match with what we see in clinical practice. So what all these trials have shown that probably HMG, HP, which is a HCG-driven LH activity versus the normal LH, probably works better in the rec as compared to the rec FSH. So again, these are very early days. Probably we need larger and more number of data to see which of the two is better. Because as I told in the beginning of my talk, we still don't have very clear-cut guidelines on which gonadotrophin to use when. I think that is the big question that we still have out in the open.
Okay, thanks. Thank you, Dr. Vaidya. What is a question is that what was the criteria used in megaset HR for receiving agonist trigger?
It was more than 30 follicles of 12 millimeters or above, or an E2 level of above 5,000.
Okay, thanks for that. One question to you, Dr. Kevin, is that uh, RFSH alpha treatment of predicted high responders, of course, uh, it's leading to one extra excellent quality blastocyst per subject, as you have depicted. But this has come with less gonadotropin utilization, shorter duration of stimulation with rec FSH. So do you think that that's also better, even though you get only one extra excellent quality blastocyst?
So, we use that term excellent quality blast based on how it looks. And I think one thing this study points out is that and actually what's really interesting about this study, and we didn't delve into, were that all these frozen embryo transfers were done with euploid embryos. So all of these embryos were biopsied on day 5 prior to either transfer or freeze, but the results were known for the frozen embryo transfers. And despite the fact that we had euploid embryos and more embryos that were quote good quality that were available for transfer, it didn't lead to a higher live birth number. It actually led to some more pregnancies, but these pregnancies resulted in bad outcomes, things we would prefer to avoid. So I think we should make the mistake of trying to infer that more eggs or more embryos translates to more healthy babies. There's I think that's one of the very relevant, one of the important and surprising features of this study is that it points that out quite clearly.
Dr. Banker, do you have any comments for that?
No comment.
So, Dr. Banker, the last question probably, which is coming, is that one of the interesting findings of this study was a difference in recurrent pregnancy loss between the two groups, which was, of course, not the primary endpoint of the study. So what might be a reason for this, or is it just by chance?
I think everything again boils down to the selection of a better quality oocyte from the beginning. And as has been pointed out, probably that is where the HMG-HP helps in deselecting the poorer follicles from growing. So that is the only possible explanation that one can come about, because the uterine receptivity, I'm sure, would be the same in both the groups.
Okay. Sure, thanks. Dr. Kevin, any comments on that?
No, I agree with that.
Okay, sure. So I think thanks. Probably there were few questions, and I request delegates if there are any few more, requesting you to please post in the chat box. And if not so thanks a lot, Dr. Kevin and Dr. Banker, for that session on megaset HR. And we would now move to the last piece of this meeting. and that's related to the panel discussion. So give me a minute to share my slides once again. Okay, so we come to the last segment of this meeting related to panel discussion on the topic control over stimulation in high responders, optimizing patient outcomes. And it gives me great pleasure for introducing our moderator for this panel discussion, Dr. Padmarekha Jirge. She is the Scientific Director, Sushruth Assisted Conception Clinic and Shreyas Hospital, Kolhapur, Editor-in-Chief, Journal of Human Reproductive Sciences, Vice President, Fertility Preservation Society of India, Executive Vice Chairperson, Maharashtra Chapter of ISAR, Managing Committee Member, PCOS Society of India. Madam holds a MBA, additionally in Healthcare Management, and a PG Diploma in Medical Law and Ethics. Her special interests are extremes of ovarian reserve, genital tuberculosis and ovarian reserve, and recurrent IVF failure. With that short introduction, may I invite you, Dr. Jirge, to invite the panelists and take ahead the panel discussions. Thank you.
Yeah, thank you, Dr. Patil. Am I audible, Amu?
Yes, ma'am, you're very clearly audible.
Yeah. How do I share the screen? It's not letting me share the screen.
Okay, maybe you can try now. There's an option just at the bottom, share screen, green color.
Yeah, I'm doing that.
Okay.
But it's not letting me share the screen.
Okay, just a minute. I have stopped sharing from here, so. It's not allowing still?
No, it's not allowing.
Okay. Another option would be that maybe you can try to just disconnect and connect again. Maybe it will allow you.
I'll get off and do that.
Yeah, on again. Yeah.
It says install Chrome extension. Click share again after installation.
Okay. So probably in interest of time, probably if we are, you could mail me and I would share from you.
Sorry?
It's possible.
Okay,
you could
shall
mail
I
me
the presentation? I'll do that in a minute.
And I will share it from you. Yeah.
Fine.
Yeah.
Yeah, done.
Okay. Just give me a minute.
I think I'll go ahead and introduce the panelists.
Yeah, sure.
Yeah. While the presentation is getting organized, it gives me great pleasure to moderate this esteemed group of panelists to discuss the issue of controlled ovarian stimulation in hyper responders and how do we optimize the results. I would like to invite Dr. Manish Banker. He has already been introduced. He's a medical director of Nova IVF Fertility Clinics. Dr. Kevin Doody, co-founder and director of Care Fertility Texas. Colonel Dr. Sandeep Karunakaran, clinical head and senior consultant at Oasis Fertility Hyderabad. During his 25 years of service in Indian Army, he has headed IVF centers in 3 of the biggest armed. Many units use a protocol where for first few days it's only recombinant FSH, and then it's either HMG or highly purified HMG. So I think some understanding has to happen clinically as far as what we are doing by mixing and matching at different times. Dr. Banker?
I am very majorly against changing drugs midway during the stimulation, because I feel every
Yes.
molecule has a different bioavailability. So if I want to give a particular drug, whether it is REC-FSH or HMG or a combo, I would always start it from the beginning. I would never switch from a REC-FSH to HMG or vice versa midway during the stimulation, because even a small difference in the bioavailability or the potency of that particular batch would play havoc, especially when we are stimulating with multiple ampules. So I would never change the combination anywhere midway during the treatment. Sometimes we might have to change the dose of that particular medication
True.
depending
Yeah.
on the response. But here also, what my view is that if 5 days of stimulation has not produced adequate response, or if it has produced really excessive response, we are probably too late. And if the response is really out of proportion or really low, I would err on the side of canceling that particular cycle, gathering or taking this information and starting afresh in the next cycle with a proper dose. Because this drug alterations midway, really you end up with a compromised cycle.
Yeah, I mean, I'm specifically asking this because it's a very common practice in many of the clinics across the length and breadth. So I'm sure you're aware as well. So I think this is something very important for us as clinicians to understand. Dr. Doody, would you agree with that when you said you make a combination of both recombinant FSH and highly purified HMG? I presume that it would be right from the beginning of the stimulation.
Yeah, that's right. And I think we also have to keep in mind the pharmacokinetics and the half-life of these things, right? So
Yes.
it can take, so FSH, HCG, their half-life is 24, 30, 32 hours, fairly long. Takes about up to 5 days to get steady state levels with those drugs. Recombinant LH half-life about 10 hours. Takes much longer. It may not get to it doesn't build up over time, I guess. So there are differences between them, and we have to. They are different molecules. We have to think about when we choose one or the other what we're doing. And I'm not saying that REC-LH doesn't work. I think it may work fine, but if I were to use it, I'd start from the beginning, and I might, because of its short half-life, maybe it's more appropriate to do BID dosing, et cetera. We did a very large REC-LH trial in ICSI patients about 20 years ago when the Luvaris first came out. It was a multi-center trial, and there was no improvement using that compared to REC-FSH, which is obviously different than the body of knowledge that we've that's accumulated since then with Menopur.
So, I mean, so you've addressed the issue of REC-LH, but what about simple urinary HMG versus a molecule containing, LH activity through HCG? Is there a very, do they behave very differently on the follicular dynamics?
Yeah. So most, although the non-highly purified HMGs do have LH in it, they still, I think, get the predominant effect through the HCG. Although there are differences between that. So, yeah, I don't know. We don't have in the U.S. we don't have non-highly purified HMG products available to us anymore. So I can't say we use those quite commonly in the early days of my practice, but I just don't have them experience with it.
Yeah. I think you both have addressed the issue of total dose if we are using highly purified HMG and the number of oocytes through the megaset HR trial.